going to spend the next 40 minutes or so of walking you through what we at Arizona Trauma have developed as the assessment, diagnosis, and treatment planning package of how to do that in a semi-formal, semi-structured way. The instruments to use and how to conduct that process. And to start that out, what I want to do is, and here's the activities that I want to spend some time talking with you about is evolving, helping you to understand how the DSM changed from the DSM-4TR to the DSM-5. And 2013, on May 12th it was one way, and on May 13th it was a different way. And the way to have some understanding of what those symptoms are, and then help you to develop some capacity for using these instruments for both diagnosis. That's one of the criteria for this course, is that you would learn how to do a diagnosis for PTSD, and I'm going to show you a really simple and elegant way to do that. And then for treatment planning, and we'll walk through that and help you to develop some capacities. And we'll start with the DSM, and I'll make this as lively as I can. And where we start is from, I think it was 2004, I think, was when the DSM-4TR came out. DSM-4 came out in 2000 or 2001, I think, and then the 2004 was the DSM-4TR. Maybe it was 2005. I can't remember which one of those years. And we stayed to DSM-4TR up until May 12th, 2013. And then the APA, American Psychiatric Association, released the DSM-5 on May 13th, de novo. No preparation, no warning. It just was like bloop, bloop, black and white. And a lot of people scrambled to make instruments to be able to now fit to do the norming and psychometric properties of instruments that were organized around the DSM-4TR to do diagnostics with that. They had to change it all. So it was a period of flux. We certainly now are fully ensconced and rooted in the DSM-5. But there are, I still ask when I do the training, how many of you are still diagnosed with PTSD out of the DSM-4 or TR? And there's usually 4 or 5 hands in the room, folks that are still doing it from, 5 years later. The DSM-4 TR had, the way that PTSD was conceptualized was it was in 3 primary diagnostic categories. There's really 6, but 3 primary. There's criterion A, which is the event, and we'll talk about that in a minute. But the 3 primary diagnostic categories were criterion B, which in the DSM-4TR was called re-experiencing. There were 5 symptoms. Those were the flashbacks, nightmares. There were 5 of those, and you had to have 1 of them to diagnose PTSD. And then criterion C was called avoidance and numbing. There were 7 symptoms in criterion C, and you had to have at least 3 of those 7 to diagnose PTSD. And then criterion D was called hyperarousal. And those were all the anxiety symptoms associated with PTSD, the activation symptoms. And you had to have 2 of those, 1, 3, 2, total of 6 symptoms to be able to diagnose PTSD. And then May 12th came, and it shifted to 20 symptoms, from 17 to 20, and from 3 to 4 diagnostic categories. Still obviously had criterion A, the event, and you see that the names changed a little bit. Criterion B, instead of being re-experiencing, became intrusion. Criterion C, instead of being avoidance and numbing, became just purely avoidance. What they did was they kind of sliced off the end numbing symptoms and moved a bunch of those to criterion D, which is called negative alterations in cognition and mood. And there are 7 symptoms in that criterion. And then hyperarousal, which was previously criterion D, now became criterion E. And instead of hyperarousal is now called arousal and reactivity. from 17 to 20 symptoms, from 3 categories to 4 categories, but still, notice up there on the screen, 6 symptoms for the diagnosis of PTSD, but a different distribution. You have to have 1 symptom in criterion B, 1 symptom in criterion C, 2 in D, 2 in E. So I want to walk through it and help you to kind of get some understanding of what the symptoms are and a little bit of understanding of how those symptoms impair functioning, and do this with as much expediency as I can. So, criterion A changed. Criterion A in the DSM-4-TR said something like this, a paraphrase, but it's pretty close to it, that the person survived, encountered, or witnessed an event or events that represented actual or threatened death or serious injury or threat to the physical integrity of self or others. It's a bad sentence for those of you who are writers. But when you kind of unpack that sentence, what it means is that if your client had a hangnail that they perceived as a threat to the physical integrity of self, then it would have met criterion A1. There was A2 with helplessness, horror, or I can't remember what the third one was, but you had to have a response concomitantly with that. But what the APA did was they wanted to make that much more concise and stringent, less subjective, more objective. And so they did that in the DSM-5. So today, to get PTSD, you have to have encountered actual or threatened death, serious injury, or sexual violence. That's it. Got to be one of those 3 things. Actual or threatened death, actual or threatened serious injury, actual or threatened sexual violence. One of those 3 things. And you can encounter those 3 things in 4 different ways. 1, you can survive it. 2, you can witness it in vivo. You were there on site, you saw it happen, you saw a motor vehicle accident out on the highway. You can get it that way. But you can also get it indirectly, of learning about it. But only if you are only if a close friend or family member, now there's some grayness in that, but a close friend or family member survived or succumbed to that event. So if we hear about an incident happening in, you know, a bombing in Sri Lanka today, and you don't know anybody in Sri Lanka, you cannot get PTSD from that. You can get adjustment disorder, but you can't get PTSD. You have to have a close friend or a family member who survived or succumbed to that event through learning about it. And then 4th and final, you can get it through indirect experience, including media. But only if you have diminished consent of witnessing. So, said differently, you can't watch CNN and get PTSD from voluntarily watching CNN and seeing, you know, explosions. Now, what's important about that is that was not retroactively from May 13th. It was anterior grade. It went from May 13th forward. So if a person got PTSD from watching the events of 9/11, they didn't lose their diagnosis. That continued. But going forward, from May 13th forward, is that you can't get it via voluntary. It has to be diminished consent. So that you watching CNN and seeing, you know, horrific things on the screen, you can't get PTSD, but the film editor can, because their job is compelling them. They are in diminished capacity. It is forcing them to, not diminished capacity, diminished consent. It's forcing them to watch that. Us, mental health professionals, where we are forced by our work to witness trauma. So that's interesting to me, is that secondary traumatic stress can now be diagnosed as PTSD, and been doing that with a lot of folks that I work with that have secondary traumatic stress. They now meet diagnostic criteria for PTSD, criterion A, if they meet all the other diagnostic criteria, then they can be diagnosed with PTSD as a result of simply listening to stories from our clients. I told you I've worked with a lot of physicians, and I have one woman who was one of the facilitators with the resilience seminar that we do for this group practice of physicians, and she describes it this way, and I think this is kind of a cool way of understanding that. She says, you know, not every pregnancy ends up in complications and bleeding. Every pregnancy I see does. Not every bicycle ride ends up in a closed head injury. Everyone I see does. Not every home improvement project ends up with a missing digit. The ones I see do. And what impact do you think her work as an emergency physician in inner city San Francisco has had upon her perception of the world? How has that changed the way that she perceives the world? Much more dangerous, just from her work. That she has now increased perception of threat, which produced an increased arousal, which for a period of her career produced increased distress and symptoms. She's doing a whole lot better now, but as she's learned to do self-regulation, but there was a period there where it was really painful for her. So that's how you get PTSD, is that you have to have encountered actual or threatened death, serious injury, sexual violence, either survive it, witness it happening in real time, learn about it happening to a friend or close family member, or indirectly experiencing it through diminished consent situations. That's criterion A. Criterion B, interesting name change. You see that it was, in the DSM-4-TR, was called re-experiencing, and re-experiencing intimates that the person is going back to the trauma and kind of perseverating on the trauma and doing that somehow with intention. But with the name change, we're getting it, I think, a more accurate description of what it really is. It's not the survivor's not going back to the trauma. Instead, the trauma is coming forward and hijacking, intruding upon perceptual system of the present. And you see, those are, the language is almost exactly the same. They brought those same 5 symptoms from the DSM-4-TR into the DSM-5, except for, excuse me, as I said earlier when I was talking about the history and Cornelia Wilbur, you see on item number D3 is the word dissociative, and you don't see dissociative anywhere in the previous iterations of the DSM. That there was this split, this demarcation, that acute stress disorder has always had depersonalization and derealization as one of the symptoms for acute stress disorder. But that's from 1 to 30 days. That somehow on the 31st day that dissociation kind of went away, and that's just, you know, irresponsible in terms of diagnostic criteria. And I'm happy to see that the APA has said, you know, in the 21st century, enough of that kind of separation, that PTSD is a dissociative disorder. Flashbacks are a dissociative experience. That's what it is. It's where a person is taking their sensory cues not from the environment, but instead from the memory. That's dissociation. And in your manual, and under the link for this module is, I copied from the DSM-5 all the diagnostic criteria, and you can read along with these with me if you'd like, if you want to download that PDF or print it out. And you see that the rest of these are exactly the same. These are the symptoms that intrude into present functioning. And we're going to asterisk this because assessing these symptoms really determine the second half of treatment for us, is what happens with these symptoms. If those symptoms perseverate, then we're going to be going back and doing some work with their history. If these symptoms dissipate through early treatment, then we're just going on forward. We're helping them to continue to move on into the life that they want to live. We are not going back. So monitoring criterion B symptoms is a real central issue of 21st century trauma therapy. Cool. So next criterion is criterion C. And in the DSM-4-TR, that was called avoidance and numbing. In the DSM-5, it's just avoidance. So what they did was they kept the two purely avoidance symptoms in criterion C, and they moved all the and numbing symptoms to this new criterion D that I'll go into in just a second. So what are the criterion C symptoms? They are avoidance of trauma-related thoughts and feelings, avoidance of things that remind the person of the trauma, situations, people, places. And we're going to talk about, here in a little while, about the importance of adding. You know, a lot of treatments just do imaginal exposure, just doing historical stuff of going back to the trauma. But a big part of trauma treatment that always has been, that is a centerpiece of prolonged exposure, is using a cognitive behavioral technique called direct therapeutic exposure, which is also helping coach your clients to begin to confront the things with which they are avoidant. Now, the problem is that a lot of those CBT treatments, even though they give lip service, when you watch it happen in session, they do not put emphasis on the importance of activating reciprocal inhibition in this process. That instead they send their clients out to brute force confront themselves, to go to open spaces, to go to the mall, to go to the graveyard. And they don't teach them to do that concomitantly with lowered arousal. And that is, I think that's less than useful. That's my bias. Is that we want to teach folks to be doing the regulation, dialing down, so that we are helping them dissipate and lessen the distress that their world produces for them. A little side note here is that it's unfortunate that this diagnostic criteria only has 2 items, because with only 2 items and needing one of them, what's going to happen is this is going to produce some false negatives. That's not good diagnostic construction. But they didn't consult me on this. And then criterion D. Criterion D is a brand new criterion, and it's called negative alterations. Negative. That's I'm going to reference that word. Negative, because that's kind of what it is. Negative alterations in cognition and mood. So those are 2 different things. The thoughts, distorted perceptions, and mood disorder, mood dysregulation, are a result of post-traumatic stress. And I could spend an hour talking about that, and I'm not going to. So let me walk you through these. What they did was that 5 of these items are either exactly brought from the DSM-4-TR or permutations of that. Permutations of the symptoms that were kind of refined language, a little bit tweaked differently. But let's start with the 2 brand new symptoms. Remember that we said that there was 17 symptoms in the DSM-4-TR. There's 20 in the DSM-5. 2 of those brand new symptoms are D2 and D3. Persistent and distorted negative beliefs about oneself or the world, and distorted blame of self or others, or distorted consequences. So to give you an example of that, how many of you have ever worked with an adult survivor of childhood sexual abuse? You build a good therapeutic relationship with that adult survivor of childhood sexual abuse, and by the 4th or 5th session, they will share something with you like this. I believe that there's something so toxic inside of me that if I get close to another human being, I will contaminate them with my toxicity. That's a good demonstration, a good representation of that distorted perception of oneself. It's not toxicity, it's pain. And the contamination is perceived threat and anxiety. For those of you who have ever worked with a rape survivor, first session with a rape survivor for D3, you'll hear these words: if I would have only. That's distorted blame. What causes rape 100% of the time? Rapists. That's right. And what you have with rape survivors is a lot of time they look back on it retrospectively and they begin to own some of the shame and responsibility for their rape. And it used to really tweak me, and I would fight with my clients. But today what I do, when I hear them start to do that, I say, here's what I say. Yeah, it's really hard to look back on that and realize how out of control you were, isn't it? And I try to do that a little bit more gracefully, because that's what that is. That's a retrospective way of being able to look and kind of think about the rape with them having some control, kind of retrospectively and cognitively overgridding it with, if I wouldn't have done this, if I wouldn't have done that, this wouldn't have happened. When, yeah, it probably would have, no matter what you did. And that's an important way to do some cognitive restructuring. Now, the rest of the items are directly from or permutations of the DSM-4-TR. But look at, here's some also screwy construction in this. Look at item D4 and then item D7. D4, persistent negative trauma-related emotions, and D7, the inability to experience positive emotions. If a person answers yes to D4, what's the chances that they're going to answer yes to D7? Pretty high. And what you got there is artificial inflation, where C, because it only has 2 items, you're going to get false negatives. In D, you're going to get false positives. Again, not good construction, but that's where we are. I will say one thing about the DSM-5, that it's kind of not clearly demarcated, but there is also the loss of one symptom. So first of all, what you're seeing with the change of the symptoms is a lot more weight diagnostically put on the perceptual sequelae of trauma. That's been the movement with the DSM-5, is more attention paid to what impact does the trauma have. 2 brand new symptoms about perceptual distortion. But the one that there's one symptom that was in the DSM-3, 3R, 4, 4TR that is not in the DSM-5, and it's a little bit bothersome to me that they took that out, and that is a sense of foreshortened future. And I think that they got that with D7. I don't think that they did. And that sense of foreshortened future, exaggerated startle and a sense of foreshortened future have always been the 2 thumbnail symptoms that let me know that a person probably has PTSD. Is there's no reason to have exaggerated startle unless you've been scared to death in your life. So people that have exaggerated startle, it kind of is a clear pointer to that they probably have some post-traumatic stress. Maybe not D, but definitely PTS. And then also that sense of foreshortened future, hopelessness, the idea that the future is dangerous, only makes sense unless there's some organic condition. It only makes sense that they would have that perception based upon their previous painful learning. So that's criterion D. And then the final criterion is criterion E, and as I said in the DSM-4-TR, that was called hyperarousal, and now it has been, the name's been changed to arousal and reactivity. Items 1 3, 4, 5, and 6 are directly from the DSM-4-TR. No change in any of those, but item D2 is a brand new symptom, and that's self-destructive or reckless behavior. And let me say just a word about that. I'm going to open up a little box here because I didn't do it during the self-regulation part. And this is cool. This is something that this will make sense to you now that you know what you know from this course. People who cannot self-regulate, one of the ways that they use to manage anxiety is they use absorption. They find themselves constantly absorbed in environmental activities. And just like any addiction, you know, I hope that you also have gotten that. All addiction, whether that is process or whether that is substance, all addiction is an attempt to use an external agent or an external process to manage arousal, to manage a dysregulated autonomic nervous system. That's the purpose of all addiction. And as you teach people to self-regulate, they start to have choice. A person who does not have the ability to self-regulate does not have choice. Once they have developed that compulsion, they no longer have choice. That every time they experience withdrawal, they lose neocortical functioning, their space collapses, and they are compelled against their will frequently to use the chemical or use the behavior. What happens for a lot of people, the way that they manage their anxiety, their fear, all of those perceived threats, is that they get environmentally focused. And Bessel has done some really neat work on this, and he calls it the Mohawk. And what they found over the past 4 or 5 years in doing brain imaging studies is that as people, he calls it the Mohawk, which are the medial brain structures, including the anterior cingulate and the frontal lobe functions here, and all of that. And as those go away, and those are the first, when dysregulation happens, when the anxiety goes up, those are the first to diminish in their functioning. As the person diminishes in their medial brain functions, then what happens is they lose the capacity for self-awareness. And what happens is all their attention now is on the environment. Well, the cool thing about that is when a person is totally absorbed in their environment, I work a lot with nurses. I've done a lot of compassion fatigue treatment and resiliency work with nurses, and I hear from a lot of nurses. I've heard this, countless times, scores of times, is I'm so busy, I don't have time to go to the bathroom in a 12-hour shift. That's crazy. You always have time to go to the bathroom. You just have to assert yourself and take it. But what happens is that those nurses are in a state of such heightened arousal while they're at work that they stay totally externally focused and absorbed, that they don't even have awareness of their physiology that they are needing to void. They don't even feel it. And that is the way that people who can't self-regulate, that's what they do. And the problem with it is like any addiction, it requires increasing high levels of intensity to be able to get the relief. I have a Ducati, and I frequently ride that Ducati pretty fast, north of 140 miles an hour. And what's happening to me when I'm at 140 miles an hour on my motorcycle is my attention. My heart, it's interesting, my heart rate is not all jacked up. I'm not at 120 beats a minute. I'm at about 85 beats a minute. Higher than normal, but it's probably hanging out, on the Yerkes Datsun, I'm probably hanging out right there somewhere around peak capacity. But where's my attention? It is 100% on the environment, totally. And I am at peak capacity, peak attention. Now, what that gets me is that if that were my way of coping, I would constantly need to do that to get out of the distress that was in my body. And that's what you find. A lot of people who are coming into your office who are trauma survivors have learned that's the way that they cope with their anxiety, is that they need to have things which are intense enough that deliver them out of themselves into being totally engaged. And when they don't have that, they complain of boredom. Once you start self-regulating, you're never bored again. There's just too much to life. There's too much going on. You can always find something that's interesting and engaging, but you can't always find something that is so intense and so engaging that it completely delivers you out of the distress in your body. Once you learn to self-regulate, you're never bored again. That boredom is only when you need something intense enough that is so engaging that it gets you out of your body, delivers you out of the distress that you are feeling. And that is, what happens is that's a treadmill that's getting steeper and faster all the time. It's just like any addiction, is that tolerance and withdrawal are beginning to come into play on that. And this is where you're going to see, especially with that D2, is self-destructive and reckless behavior, is folks that have used that as a coping, is that they engage in those behaviors. And the important thing is that I ride my motorcycle now. That's intentional. I'm doing that not as an anxiolytic. I'm doing that as a sport, and it's something that I choose to do. And I've had a whole lot of 30 years of more than that experience of riding, and so it's something that I do because I choose to. For early on, it was something that I did because it was a way of coping with a chronic state of anxiety. So those are the symptoms. And then, we've got, they have to have been longer than a month. They have to have produced distress and impairment. And I've just never seen anybody that meets diagnostic criteria for PTSD that doesn't have some degree of impairment. I think that's kind of a dumb thing. And that they are not due to medication, substance, or illness. And that's a diagnostic criteria for PTSD. So I'm going to ask you to turn in your packet and find, we've already kind of gone through the aversive childhood experiences scale, and as I said when I walked through that in an earlier capsule, is we thoroughly recommend that you use the aversive childhood experiences scale at intake. It is both a screening and it is a really good psychoeducational tool. So I'm not going to add any more about that. We already kind of talked about that. I am going to ask you to turn now to, in your manual, it should be under the link on this part, the PCL, which stands for the post-traumatic checklist. Or you will also have a downloadable link for the whole manual, so you can go find that through the table of contents. But I'm going to ask you to actually go to the instrument of the PCL. That is developed by the National Center for PTSD. Once again, there on the slide is the web address, and you are welcome to go to that web address, and your tax dollars built this, so it's downloadable. You are welcome to use this. It's fair use for any clinician, and it's a really useful tool. And when you notice that the PCL Part 2, it looks like this. It has 20 items, and just read through some of those items on the PCL. And as you start reading through, and you can sample like 1 and 7 and 10 and 17. And when you look at those, you start seeing that what all those 20 items are is those are the 20 symptoms of PTSD. Each one of those is, item number 1 is B1. Item number 2 is B2. Item number 6 is C1, because we got 5 and B. So 6 is C1, 7 is C2, 8 is D1, and we've got 7 items in criterion D, so that 16, 15, 16, 17, 18, 19, 20. Yeah. So item 15 is E1. Had to do a little math there, sorry about that. So what I'm going to ask you to do is, if you've got this printed out on a paper, a page, then what I'm going to ask you to do is, on items 1 through 5, I'm going to ask you to put a little bracket so that you got that items number 1 through 5 in a bracket over on the left-hand side there. So it's just a little squared off bracket, and then 6 and 7 in a bracket, 8 through 14 in a bracket, and 15 through 20 in a bracket. And you see what we just did is we separated those into their diagnostic categories. So on the left side of that first bracket, I'm going to ask you to put B, Bravo, -1. Next to the left of the second bracket, C, Charlie, -1. Third bracket, D, Delta, -2. And the last one, E, Echo, -2. And so there's your diagnostic criteria associated with the PCL and how many symptoms you need in each of those diagnostic criteria to be able to diagnose PTSD. Now all you need is the CUT scores. And you see this is a self-report instrument. You can give this to your client at intake. And it has the scores of a Likert scale but ranging between 0 and 4. And if your client circles a 0 or a 1 on that item, then it means it's subclinical. They have not met threshold for that particular symptom. So 0 and 1 is subclinical. But items that on any item scores of 2, 3, or 4, if they circle or check a 2, a 3, or a 4 on that item, it is your client endorsing that particular symptom. They're saying to you, yes, I have this particular symptom with a 2 or 3 or 4. Now, let's see if you're tracking. Items 15 through 20, how many items does your client need to have a score of 2 or 3 or 4 to be able to diagnose PTSD? 2. Items 1 through 5, how many items does your client need to have circled a 2 or 3 or 4 to be able to diagnose PTSD? Items 6 and 7, 8 through 14. There's how you diagnose PTSD. In a really simple, elegant, 2-minute, 3-minute process, you have now you have assessed from your client whether or not they have these symptoms, and what's nice is you've got, with one instrument, criterion B, C, D, and E documented that you can now put in your file. And if you look in your manual, on the preceding page of from the PCL, there is a second part of this that I used initially. This is also from the National Center, and you see it's an assessment for criterion A for the event. And when this initially came out, it took them, I don't know, 10 months or so, 8 or 10 months before they finally, because they had to scramble and rebuild this for the DSM-5. And when it finally came out, I used both these 2 pages, and I gave it as a self-report to my client. And what I found was that several of my clients, most of my clients, got really confused with trying to do this criterion A part on the previous page as a self-report. So what I started doing was I stopped giving them that. I gave them these 20 questions, but I still printed out the information for criterion A, and through the interview and with the next instrument that I want to show you, I got criterion A covered, and then at the end of that first session, once my client left and I was writing up the notes, I would go check, 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 check that they had met criterion A, stapled it to part 2 of the PCL, and now I've got A, B, C, D, and E documented with one instrument. And I invite you to use that in your practice. It's a nice way to be able to, simple, easy, elegant way to diagnose PTSD. And then finally, our third and final instrument that we advocate the use of is an instrument that I developed back in 1996, When I was doing my fellowship with Lewis Tenen, and we started the very first on the planet that I'm aware of intensive outpatient program for psychotraumatology at Western University School of Medicine, Department of Psychiatry at their psychiatric hospital in Morgantown. And I was in charge of finding the outcome measure to assess treatment effectiveness. And I looked through all of them. I was, kind of surveyed the SCL-45 and the SCL-90, the symptom checklist, the GHQ-30, the impact of events, the CAPS, looking at all of those different instruments. And I didn't like any of them. So what I did was I built my own. And you can take a look at that instrument in your manual, the TRS, and look at the TRS Part 2 and start reading through some of those items on the TRS Part 2 and start noticing what they look like. And here's what the TRS Part 2 looks like. It's got that Likert scale. And I will say that I developed the instrument and then I have done all of the psychometric properties with that. It has it's good reliability, good validity. It has a Cronbach's alpha of 0.86. It has a convergent validity with the impact of events of 0.71. So it measures what it's supposed to. It holds together. I've used that. I've normed that with 3 groups: with trauma survivors, with mental health professionals, and with college students. And it's a pretty useful instrument. And I gave it to the public domain in 2000, so you're welcome to use this in however you'd like to. It's free. No intellectual property or copyright issues on it. And when you look at Part 2 first, we'll come back to Part 1. When you look at Part 2, you look at those items, and what are they? You see that they are the symptoms of PTSD flipped 180 degrees. So instead of what the symptom or what the impairment is, what we're looking at is how much recovery from that particular symptom does our client have. So it's solution focused. And that was one of the reasons why I wanted to do something different, because there were no solution focused instruments at in 1996. And I wanted to start socializing clients towards what does recovery look like instead of what does pathology look like. And so for that reason I like it better. And this is originally what it was built for was a repeated measure outcome instrument, but it also is really useful at intake. Because at intake you get a baseline, and what your client does is they just put a hash mark on this line, and you see that each of those lines are scored between 0 and 100, and on there is a dot at each multiple of 10. So if they put the line on the dot, then you give them that multiple of 10. If it's between the 2 dots, then you give them the 5 between that. So 75 or 60 or whatever it is, and you write that number over in the gray box. And then add up all those numbers in the gray box. And that's going to give you a number between, because it's every one of the boxes between 0 and 100. And when you add them all up, you're going to end up with a score that is between 0 and 1,000. And then you divide by 10 or move the decimal point over 1, which is going to give you a number between 0 and 100, the mean score on this. And what that mean score is it's a thumbnail. It's an approximation, but it's telling you how much recovery from the traumas of the past does your client have. Is that a useful metric in early treatment? I think so. It's been really helpful to me. And what we found with this instrument is that it's got a cut. So the important thing about the TRS is that it's not diagnostic. You cannot diagnose PTSD. But it is useful in telling you how much impairment their clients have. And that's really useful in early treatment, especially at intake, to help you to start to conceptualize what treatment looks like. So the cut score is 75. A person can still have, and with the TRS, the higher the scores, the better. So a person could still have like a 90 on the TRS and still meet diagnostic criteria for PTSD. But if they've got a score of 90 on the TRS, what that's telling you is that while they still meet diagnostic criteria for PTSD, they have minimal impairment. And what that tells you is that you can now work pretty aggressively with this client, that they're not suffering impairment in their ADLs. They're able to parent and go to school and go to work and do the activities of life and still have quality of life. As the scores start dropping off below 75, then what you're seeing is increased impairment. So if you got somebody that's got a score of a 35 on the TRS at intake, what that's telling you is, you know, as we're going to get into in the next capsule, you know that you're going to be doing not only self-regulation, but you're going to be teaching, you're going to be doing some stabilization skills. You're going to help them to develop some skills and doing some case management with them to help them to get stable and help them to develop the skills that they're not overwhelmed by their lives. So it helps you to do treatment planning. And for those of you who are kind of conscripted to do written treatment plans, the nice thing about the TRS is anything that has a score less than 75, you can pop that off of there and there's your treatment goal. And you can report the baseline, whatever it was that whatever score they got. You know, if they got a 48 or 45 on item number 7, then you can pop that off of there and put that as your treatment goal, and then you can now, with repeated measure, monitor their progress toward that treatment goal and report that empirically rather than and quantitatively rather than qualitatively. And a lot of third-party payers like that. And that's the real purpose of this. As I said, I give it every 4 sessions. That's what has been my rhythm throughout the past 20 years, is when I'm doing private practice, I would give this every 4 sessions. And what I would do is I'd look at it and I'd see where we were making progress, but I was also paid really a close attention to the areas that showed no movement, and especially the ones that showed the scores getting less instead of getting greater. And what that meant was that the next session I wanted to address that, because you're not always monitoring all of these areas. Sometimes you get so myopic about working on one thing in treatment that you forget about all these other areas. And what's nice is that the TRS is a nice monitoring, kind of ongoing monitoring of looking at multiple spheres of the person's life, and so for that reason it's useful. And then finally, look at number 5. The way you score number 5 is you see that there are 2 items for number 5, 5A, 5B, and they put the score on 5A, and you put that score in the first box there and B in the next one, and you mean those 2 scores to get the total score for 5. Add them together, divide by 2. And but the real reason why I use this is, first of all, in early treatment, first session, don't you want to know why your client would have any score less than 100% on 5A? If your client is not 100% safe, if they are encountering regularly real danger, it is incumbent upon us to talk about that a little bit and to do the assessment and discernment. And if we find out that they really are habitually and frequently in real danger, what's our job? We shift gears. We're not doing psychotherapy with that client initially. We're doing case management. We're building safety plans. We're helping them to get where they are not in real danger and to manage that. So that's helpful. But also, what I do is I put this away, and then in the second or third or fourth session is I start the session by pulling this out, and I say to my client, I hand it back to them, and I say, I noticed on that part A of number 5, you put that I am safe 70% of the time, and you put I feel safe 20% of the time. What's up with that? and you let your client talk about that a little bit. And what this becomes is a perfect entrance, a way to engage in the discussion about perceived threat in the autonomic nervous system, and then on to teach self-regulation. So that's how I use this. It's kind of a portico, an entrance way into talking about autonomic nervous system dysregulation and the way that perceived threat does that. And that's been another useful tool for me. So a lot of stuff on this particular instrument. So then let's back up now to part A. And what is that on part A? It's a trauma inventory. And do you think that might be important to do with your clients at intake? I think it's crucial. And, you know, sometimes folks who attend this training say, isn't there a chance that you're going to trigger your clients with this? Yes, there is. Yes, there is. And I want to be absolutely trauma sensitive, and I want to be trauma informed. But I also, you know, I'm a board certified expert in traumatic stress. People that come to see me know that we're going to be talking about trauma. So what I'm not doing is I'm not tenderfooting around this. I want to come forward and say, you know, we're going to talk about this, and this is absolute apropos to discuss, and let me know if you're having any difficulties, and I'll be happy to help you to learn some skills so that you will be able to walk through the talking about this. But what I don't want to do is I don't want to be, it's the right word, I don't want to be fear-based in talking to my clients about their trauma. I don't want it. For 15 years or longer, I treated trauma survivors as though they were fragile. And even though I would have called myself a psychotherapist, really what I was an advocate. And what I believed, and I didn't know this, I wasn't conscious of this belief, it just was the way I was working, was that I believed that the trauma survivors that I was working with were weak and fragile, and that they needed me to help them, to be their advocate. And then I grew up and did some of my own trauma work. And what I started discovering, instead of that trauma survivors are fragile, they are in the top 5 percentile of resilient people on this planet. How do I know? Because they got a bunch of those on that list, and they've already survived them. They've already done the hard part. They are, by prima facie evidence, the most resilient people on this planet. And I want to treat them with the respect and honor that they deserve, which means that I'm not hedging on addressing and talking in a matter-of-fact, real way with my clients about their trauma history. So it starts with this. And the other reason why this is important is I was married to a psychiatrist for several years, and when she had a patient come in and complain of feeling fatigued and hopeless and sleeping all the time and not wanting to leave the house and intermittent thoughts of suicide, what'd she diagnose them with? Major depression. And if they came in saying that they were stressed out and they couldn't concentrate and they couldn't sleep and that they were irritable and going off and having, you know, constant state of distress, what'd she diagnose them with? Anxiety disorder. And if they had both, what'd she diagnose them with? Bipolar, mostly. And do you see that if she would have had this sitting in front of her and the person would have had, you know, 6 or 8 or 10 of those things checked and multiple times, she would have not jumped to a mood disorder as a diagnosis first. She would have ruled out the trauma as being the cause of what's going on with the person. And that's what this does, and that's what the ACE does. And this helps you also to get criterion A. So those are the instruments that we do in the assessment. I want to take just a second and talk to you about the CAPS. I do not expect that you're going to ever use the CAPS. There's really only 3 places that you would ever use this, and that's for determining combat disability in the VA, and that's one of the places that it's used. In clinical research of looking at treatment effectiveness, they use the CAPS pre and post. And forensically, the CAPS is used. It is a big, ugly instrument. It takes 2 to 3 to 4 hours to do it right. Almost always my clients get triggered doing the CAPS. And what the CAPS is it is a structured clinical interview for the diagnosis of PTSD. And there included some samples in your manual of some of the questions, and you can see what it does is it gets your client talking about that particular symptom, and then it moves them into discussing the frequency and intensity of those symptoms, and you collect qualitative data from your client, have them talk about that, and then in each item you go back and clinicians score that. So you ascribe the scores for intensity and frequency, and then you mean those 2 scores and you get a severity score. It's big and ugly. It's challenging and difficult to use. It takes several months of apprenticeship and coaching and supervision to be able to use the CAPS with efficiency. And as we develop more advanced courses, that would be one of the things that I and we will teach. But I want you to just have some familiarity with it, and I'm going to ask you to read through it, because what you're going to learn as you read through the CAPS is you'll see the way that each one of those symptoms impair functioning in your client's life. And so there is learning to be gained from reading that and just looking through it. And I'm going to ask that you do that.